Guess it's not going to. Let's see.
Can if you could, can you turn up the volume on your laptop? Because I think the big issue is that we're not going to be able to hear Dan online.
I think that we get this.
Why don't we just turn the volume on for now?
Okay, that's fine.
Hey Dan, can you talk?
Hey, Karen.
Watch yourself.
Everyone, please be patient while we fix some technical issues.
Testing 1 2 3. Testing 1 2 3.
Yeah, we can hear you on my phone, but we can't hear you in the room, so we're just hoping to solve that.
Yeah.
Just FYI, the recording is on. Just no expletives. It's close. just letting everybody know. I mean, you can say whatever you want, it's just me.
I have to go on the side that it's not that one. Yeah. Okay. Oh, there you go.
All right. Dan, can you talk to us again?
Testing 1 2 3.
Okay, one sec.
Thank you. Sorry I can't be with you in person.
That's okay.
Making progress.
We're almost there.
See.
Dan, you want to give us a test again?
Testing 1 2 3. Testing.
We don't see Dan.
Dan's up on
Yeah,
top.
he's up there.
Yeah.
He was talking just then.
Hello.
Testing 1 2 3. Testing 1 2 3.
Oh,
Can you see me?
I
I can see you. I can
Yeah.
see and hear.
Yeah, it's just audio in the room. I can't put you up on my phone because then we get feedback. Okay. Well, let's try our best.
Oh, what was it? Let's do this.
Okay. You guys all right with that? Listen very carefully if Dan talks.
Okay.
All right, we will call this meeting to order. Thank you, everybody, for your patience this morning. Don't believe we have any changes to the agenda. Do we have an approval for the January 10th meeting minutes?
I move we approve the January 10th meeting minutes as written.
Second.
All those in favor say aye.
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 I see Dan saying aye. All right, meeting minutes are approved. Anybody for public comment? I don't seem to see anybody online. Looks like it. Nobody here present in the room. I guess we don't have any. Oh, I'm sorry. Yes. Like to welcome Commissioner Jack Hepestake to your meeting. I think this is your first.
Yes, sorry I missed
assigned.
last month. I was deathly ill. I didn't think it would be good form.
Well, it would
For
have
me
been a
to
good
come to
place
the
because you
meeting-
have a doctor right here.
I think I was pretty contagious, so I thought the better choice was to miss the first one. So I'm glad to be here. Thank you very much.
Welcome. And also wanted to say thank you to the staff for the lovely card to the board. Appreciate that and little treats. So thank you guys. That was really nice of you.
Very kind.
Okay, so we don't have any unfinished business, so we're just gonna pop over to.
right, let's look at December's financial
Oh,
statements.
can I have a copy of the?
Oh, goodness, yes. All right,
Thank you.
in December, we're halfway through the year. We have a bank balance of 409,000. Reserve amounts 517, so we are still not in compliance in December by 107,000. For December, we brought in 61,000. We're gonna subtract out 93,000 in salaries and wages, about 17 in operating expenses with a deficit of 50,000 for December. Fiscal year, we've brought in total about 597,000, which is 13% below budget currently. Salaries is at 685,000, which is about 3% above budget. And operating expenses 192,000, which is about 5% above budget currently. Accounts receivables still less than what we're used to at 169,000, which 61,000 of that is the West Virginia Treasury, about 36%.
So it's our medical billing that's now running behind.
Collecting that.
Any questions for Amber? All right, we'll do the January preliminary before we vote.
The only question I have on that is Charlie still with the firm or?
She is.
Okay.
I've kind of taken her role and now she's on top of me reviewing and making sure all these look nice and good for you guys.
Okay, thank you.
Yeah, she's still, very much in touch with us.
Okay.
All right, for January, we are now 58% through the year.
So we need to vote on
The preliminary review of January before we do the vote of December. Because there's some trends differences, so I'd like to have everybody see the full picture of the direction of things are going versus the month, especially during this time of year.
All right, currently in the bank is 405,000 that's recorded in QuickBooks. However, upon reviewing, we're missing about 78,000 of deposits that haven't been recorded. Mostly, I mean, with Gino gone, things are just a little timing right now. Conservative reserve is 453,000, so it's showing that we're short 48,000, but if we take into account the 78 that we're missing right now, you should be within your reserve requirements.
Not missing, just haven't been booked yet.
Okay, that's good way of doing it. Sorry.
It's got a much better
Yeah,
ring
yeah.
to it.
It's not missing, it just hasn't been recorded. Okay, good point.
Thank you.
All right, for January, we recorded revenues at 205,000, less salaries of 112,000, and operating expenses of 21,000 for a surplus of 72,000. Year to date, we've got revenues of 830,000, which is about 11% below what we budgeted so far this year. Salaries 797,000, which is 4% above budget, and operating expenses at 213,000, which is about 3% above budget. Currently, fiscal year to date, we are at a deficit of 207. That is not unusual for this time of year. It's very comparative to last year.
Do you think that the small, above budget in terms of the expenses, the salaries and the operating expenses, is that due to inflation? And do we need to account for that more in the future? What's
Inflation could be a variable in that, yes.
yeah, that's what I'm thinking. So maybe we should take that more into account going forward.
Right. Accounts receivable has gone up in January to 219,000. Yeah, 40% of that is the West Virginia Treasury, 11% is the NEHA, which has been deposited, just not reported. And then the remainder of the medical receivables.
Any questions on the January preliminaries? Okay. Is there a motion to accept December's financial report?
I move we accept the December report.
Second.
Any discussion? All those in favor say aye.
Aye.
Dan is recorded as an aye. We'll move on. Thank you, Amber.
Thank you.
Thank you, Amber.
All right, agency report. So environmental activity.
So I do have some amazing news. Both sanitarian positions have been filled.
Great news.
Thank goodness. So we have one younger gentleman who's in training at Charleston right now.
Is that
as well.
Brandon?
No, well, in addition to Brandon, we also have Brandon. So we decided to go ahead and send Brandon to Charleston because the second younger woman that we hired is unable to start until closer to March, so she'll miss the beginning of training and therefore will have to repeat those courses next year. She will still be eligible to undergo our well and septic training in April, so we're thinking that once she gets started and gets trained up, we'll probably have her primarily working in well and septic, which will be fantastic because as I've been reporting, these numbers are not slowing down. We're looking at January and we received 27 well and septic permit applications. We're receiving well and septic information requests above average at 29. And we're doing a lot of finals and a lot of renewals and site evaluations. So right now that program has been the bulk of our time that the sanitarians are spending.
Just curious, beside the training down in Charleston, what other qualifications does a candidate need to meet to be a sanitarian?
So upon hire, they have to hold a bachelor's degree in any field, in any academic field. They complete up to 6 months of training and then they have to pass a certification exam that is administered through the state. That is at the end of their training. And then upon passing their exam, they're then eligible to undergo what's called on-the-job training, where a state official gets assigned to them to come out and actually assess whether or not they are competent enough to be able to perform inspections independently.
So aside from the training,
Mhm.
all they need is a bachelor's degree.
Correct.
Oh,
Mhm. Yep.
okay, thank you.
So this person that's going through training will actually be certified until this time next year.
Yeah, so the state maintains a little bit of flexibility. So what they'll do is, even though they are not going to hold a sanitarian's license, if they undergo and pass the course specific exams, so if she completes the entire septic training and passes that exam, what they'll do is they will allow her to work only in that field upon completing her on-the-job training. So that way she doesn't have to wait a full year to then start doing sanitarian duties. So that's really good for us. And then the other younger gentleman is going to be able to attend all of training. He will get his certification and he will be able to perform all sanitarian duties. We're hoping by about May. Of course, that'll be.
And the young lady already has experience.
Right, yeah, I did forget to mention that. She's coming from another state. She was currently working as an environmental health specialist in Illinois. So she's already undergone the same duties that we've done. So she'll be able to help in other ways, even if she can't independently perform inspections. She can help us with investigations, writing reports, just kind of making judgment calls on restaurants. So it'll be really good to have some experience in here. We're looking forward to it.
There's no reciprocity, huh?
No, unfortunately, the only reciprocity West Virginia does offer is there is a national certification, the NEHA exam, that they will accept. They will allow you to onboard as a fully registered sanitarian, but it's a little bit harder to obtain that because NEHA already requires you to have 2 years of experience before they allow you to sit for that exam. Otherwise, what's going on is I just want to brag on my sanitarians, the ones that we have. They knocked it out of the park in January. Mason absolutely knocked it out of the park. He handled our entire well and septic program independently throughout the month of January. I'm absolutely astonished at their hard work. Very, very proud of them. They kept this place afloat through this month, through this really tough vacancy. But there's a light at the end of the tunnel. So thank you for your hard work.
And he lost all his laptop skills. Sanitarian's way more important.
Thank you, Brandon.
So what are, tell us a little bit about your
I'm sorry.
cat and rat.
Oh, yeah, so we did, we've been looking at efficiency is the key word for how I'm trying to run this program in general, but especially with vacancies. So we did go ahead and purchase iPads for the sanitarians to use to expedite our paperwork process. So they have all their forms digitally, they're able to do it on site, have signatures, and have it sent out same day. So our inspections are getting out almost instantaneously, almost as we're in the building inspecting them.
Elon would be proud.
Right? Like, that's what I said. I was like, we're gonna doge this place. That's what I've been saying all night. Well, yes, that is absolutely the name of the game. And I'm just really proud of their hard work. They've been knocking it out of the park, and we've stayed afloat. So that's pretty much all I got.
Great work.
Yeah.
We talked a little bit about the subdivision requests coming in, and you explained to me what's involved, and we also looked at the fees. Could you discuss that a little bit?
Yeah, actually, Elliot, that when you talked about inflation, it kind of sparked something that I've been sort of brainstorming over the past few months as we move towards building our budget in May. One of the things I've been kind of thinking about is, should we revisit our fees for service? Should we potentially consider raising those fees to account for the number of hours that it takes to perform those services? To Dr. Reedy's point, a subdivision application is essentially evaluating an entire section of land and subdividing it into tracts and then evaluating each individual tract on its own. So it can be very, very labor intensive. And we did receive an application this month for 62 lots. So that would be 62 individual evaluations for one price. We do have a slight accommodation for that, whereas if you apply for more than 11 lots, then you're paying an additional $14 per lot. But even that, I think, doesn't fully accommodate the cost of labor to evaluate those lots and then go back to the office and write up the notes for each lot and each permit. So that's something I've just kind of been brainstorming. I think I'm gonna look at all of our fees and maybe do some, I mean, I'm not an accountant, but I'll call it a labor analysis, I guess. Just run some numbers with the cost of staff hours and see if I can figure out if we're on track for what we're charging for our fees for service. And then
So
I'll
we just
look
raised
for
them
those.
actually last year.
We did.
So by like 30%.
Was the one that you're talking about specifically, was it in that inclusion, that 30% increase last year?
I cannot recall off the top of my
I think it
head.
was across the
It was
board.
across the board.
So and this was the first time the local health departments were able to set their own fees. Before that, the state had set the fees, and we could be under the fees, but there was a maximum, and that now is at the county level.
Yeah. It does go to the county commission
So
for approval, so.
And it may be
Which is
something
new.
where not all fees need to be, not another across the board raise. I don't think that would be appropriate. I think a lot of our fees are appropriate as is right now. I think that it would just be a couple of those specific instances, mainly in our well and septic program where we're seeing this massive influx and it's not really accounting for the level of work that we're putting.
So maybe doing something separate are we able to do something under state code that allows us to charge differently for a subdivision versus onesie and twosie?
Yep.
people?
So you guys would be able to essentially approve that fee and then it would go to the county commission. The county commissioners would vote to approve it. It doesn't have to be across the board. You can raise individual fees.
So
Is
as I
this
had-
the first subdivision we've had submitted in a while? That's a whole subdivision.
We get probably over 100 subdivisions per year.
Do we?
They average about 2 to 5 lots per subdivision. It's always gonna be at least 2, because you're dividing a piece of land. And it's pretty common to get a subdivision with just 2, but on average, we're probably averaging about 2 to 5 per.
And do you think there's a rush of applications now to beat the impact fees?
Oh, yeah,
that are
I've
facing-
certainly seen a difference between December and January in just in the amount of interest, even if it's not actually manifesting as applications. We're seeing a lot of people renewing previously expired permits. We're seeing a lot of people calling us to ask about how to get a permit, and we're definitely seeing an influx of those applications coming in for sure.
For the subdivisions, this is preliminary, that the person may not build for years.
Right.
But you have to evaluate each site.
Mhm.
They dig an observation hole and you just be sure the terrain and the soils are adequate.
Mhm.
But then, and that the reserve area is adequate.
Yep.
That
So-
permit's only good for a year.
So it's a little different than issuing a permit. What we do is we write an approval letter that's good indefinitely, and it's transferable between owners of that land. So that's the main difference between a septic permit versus an approval letter. The other difference is if you're not planning to build, we size our drain fields off of number of bedrooms that you are planning to build. So if you don't know, what you're planning on doing, we can't permit you accordingly. So what we do instead is we just say, this lot has been evaluated and is approved for a system, essentially a system, and we'll go back and we'll size it later on once somebody's purchased that land and proposes what they're gonna build on it. But the approval is good indefinitely.
As far as the rates, what comes to mind for me, we talked about this when we did the across the board increase. I know it had been many years since we had looked at those rates, and we talked even then about an annual review. I just think that it's gonna be important to have that kind of baked in, like if there's an expectation that rates could increase, being able to speak to what our annual review process for fees are, what time of year they're being reviewed, so that there can become a consistent cadence,
Yeah.
up the chain. Cause I think the county commission has to approve the rates increase as well, and so they can expect that, in August, we're gonna receive our annual rate review. Maybe there's nothing increased, maybe there's some, as opposed to, hey, I've got a good idea, and I think it's a great idea, it should be looked at.
Yeah.
But it should be baked into an annual review, that's
Yeah.
part of the process.
Well, if impact fees are what's driving the interest right now, and those go into effect, July 1st. Then we may see a slowdown, so we're gonna increase
Yes.
rates, but
That's true.
it's not necessarily gonna be utilized, because if everyone's rushing right now, this is when the labor is happening, not after July 1st, so.
Yeah.
Okay. Any other questions for Alexis?
Good job.
Yeah, thank you.
So I'll move on to clinical report. As you can see, our numbers are holding steady. Big deviations. Are we gonna have a PowerPoint put up?
He's doing it.
There was, based on some interest that you guys have shown on the vaccines that we give, we have prepared a slide. I have prepared a slide for you guys.
Can you see the PowerPoint, Dan?
Sorry.
Yes.
Yep, okay.
So this is just one of the breakdowns that I wanted to show. This is all the vaccines we gave in the last month of January. And just to go over a little bit, I put color categories just to give you an idea. The top, meningococcal, rabies, they're all put together. They're more related to brain and spinal diseases. And then you can see the peach color, those are all our childhood vaccines. And the top blue, those are all vaccines related to airway, respiratory, ear, nose, and throat diseases. And then we have our travel vaccines, which is the green, and the bottom is all hepatitis vaccines. So these are all the ones that we gave last month, in just 1 month. Those numbers represent.
Before the
January.
hepatitis, what was the word you used?
For flu and flu,
Travel.
Travel. Oh,
So people who are going overseas and special vaccines for that.
thank you.
Seems like a lot of rabies vaccinations for January.
So this was a group of people that work with animals. I don't know if it was one of the Animal Welfare Society that they wanted some of their people to be exposed to have vaccines. So most people that are bitten and potentially could have been exposed to rabies, but the animal ran off, they get that through the emergency department. That's a relatively expensive vaccine, so we don't keep that in stock.
So, the COVID vaccines, there was 3 given.
Correct.
I suspect that one's going to be taken off the market soon, based on what I'm seeing in the federal purview of things. Because the reports I've seen is that aside from the potential side effects, which I won't go into right now, in the reports I've read, but it's now been established that that vaccine has a negative efficacy. So even based on what it's supposed to do, it's not doing it. And the side effects, we can discuss it another time because it's too depressing for me.
and that's all I have. If you have any questions.
Anything else? Okay,
So
Dr. Reedy?
did you want to give a threat prep report?
Oh,
Brandon
so-
said you had a little.
The only thing that Brandon had was that he was continuing to work on the CISA grant and hopes to have that by the end of, I think he said next month,
The cybersecurity.
the cybersecurity one.
Dr. Reedy?
And so the big talk now is about flu. I got a call from a reporter last week saying that, you know, at an all-time high or something, and that we're being overwhelmed with it. Part of the problem is that influenza is not reportable to the health department, and so most of the cases I know of I hear about someone through my social network that, you know, someone in church or work or somebody who has it. And then occasionally the school nurse will call about, you know, cluster of cases. Or if a nursing home has it, so one, you know, if there are a few cases of a respiratory virus, that becomes an outbreak. So they have to let us know. So their definitions. So we get a lot of our information the same way you all do, is through media, but then there are some reports that are available. You can go on the CDC website. So last week, I couldn't see some of the stuff, but the old stuff is available again. So this is what it looks like, and it tells you there's a lot of, compared to one from 2 months ago where it was pretty much all green, it tells you there's a lot of flu going around. But saying, well, where did those numbers come from? Those colors come from? Is West Virginia really that wonderful and wild? And so next slide. So if you break it down into
I think so.
other areas, you can see that there's actual, so this is a special surveillance network areas where they've got it by different census tracts. And we'll go to the next slide. We can see it. Yeah, so this is the same thing on the next slide. So Jefferson County is in the Washington metropolitan areas, so it's actually the brown instead of just the red like Berkeley up there. But that's looking at hospitals and other things within the surveillance network, which I do not know if Jefferson Medical Schools in Jefferson hospitals in that or not, but it's still, we are more part of this area than Kanawha, as we know, but it's sometimes misleading when we look at the aggregate for West Virginia as a whole. Next slide.
And also some of
So-
our medical care would be getting, we'd be getting from Virginia, so it'd be reporting under Virginia, not West Virginia.
What's that?
Like if I'm sick, because I work between here and DC, I'm going to the doctor typically in DC or Virginia, not here in West Virginia. So I'd be reported under DC and Virginia, not West Virginia.
Right, so a number of people showing up in a hospital would be one way. Other reportable disease goes to the zip code of the jurisdiction where the person lives. But with this, it would be where they are now. Yes.
We don't have an epidemiologist anymore, and I know you're not one, but flu all but disappeared during the COVID period. What happened? Why did it disappear then, and why is it coming back now?
So if you can wait one slide, go back just one. Yeah, okay, we can go forward. So I'm gonna just get closer. I'm sorry, this is bigger. So this is, no, I need the top.
Okay.
So this is the percent of emergency department. So where do we get the data? So one is emergency department visits. What percentage of them are due to influenza or influenza-like illness, or different definitions? And so this is going back to 23, towards the end of 23 to 24. So this is last year's cases. This is this year's cases. So and this only goes up to, well, to about a week ago. So you can see we've got a larger percent as a proxy for how many people. You know, it could be different behaviors. People go to the emergency room now, but there's more in all the age groups than last year. So that's number of cases sick enough to go to the emergency room. Next.
And this is our region,
This is nationwide.
nationwide.
And then this is different years. So 2019, 20. So December of 19 was when COVID first started in China and didn't affect us here until February, March we were the last state with a case, and it wasn't until March of 20. And it came here just as flu season was ending. So we weren't sure what was what. But that was this, this is respiratory illnesses. So in 20, we had a lot of respiratory illnesses. But this is, anyway, in 2021, you can see there were hardly any. And the thought is that our measures were where the social distancing, the masking, all those things to prevent spread. And these actually are things that were done back in 1918. Years ago, I heard a presentation of someone looking at theaters being, newspaper articles about how it was addressed then with theaters being closed and people, churches closing and all that. So it did go down. And then as we reopened in 21, 22, so the second year of it was when excuse me, 2021 season.
You have it, the green 21-22 season, so you start to see that uptick.
Right, so this is the 2021 season, and that's the
green
21-22. But as it came back, when we, went back to regular activities. The main thing is, and it comes at different times of the year. So the first season, when it opened back up, it came early, which we expected because in Australia it had been early. So there's something about that virus. This year, it's right in the middle of the season. It's coming up. One year, you can see there were a couple peaks, but so we're high by this measure. So that's outpatient visits. Next. Okay. So this is, so it's also how serious it is. It's one thing to have it, it's another. So this is a combined, so this is just influenza, and you can see how few deaths there were from influenza there, which was very remarkable to us. That in the RSV the same way, and most RSV deaths were, in little kids, and weren't that many. And then it came back, and this is showing we've got a lot, but as of today, I can't say it's more fatal. And then the fatalities become who's dying. Is it someone that's severely disabled and elderly, or is it 6-year-olds or 19-year-olds? And so the pediatric mortality is separate, but we are seeing childhood deaths as there are every year. I think there are about 130 or so childhood deaths from flu a year. But you can see that these are, weekly deaths, 700, 800. Next. This is COVID deaths by week from the start. And you can see COVID deaths have they continue to go down. And that's a typical epidemic curve. You never know if it's going to change and become worse, or when the next disease comes along. People call and ask about the bird flu and this flu and that flu.
Or if the data is to be trusted.
So that becomes a matter of trust.
Yes,
And
it does.
I trust the data, at least locally, because I was able to see individual test results and death reports and hospital courses, and talk to patients. So the data points I see were consistent with what was seen. The next. So this is pneumonia, influenza, COVID, and these are the deaths. So you can see that the blue shaded is COVID deaths. The orange is influenza deaths. And this is weekly numbers of 2,000. So we can see COVID deaths, as we just saw, are going down. We have seasonal influenza deaths. I was asked back here by one of the board members, at what point is COVID no longer a big concern? Well, we've gradually been getting there, but my answer then was, well, it's less of a concern once the deaths are down to the level of influenza. Well, that's what we're at. It's a concern, but it goes all year long. The good thing is it's still mostly those people who are already vulnerable to death from a lot of other causes, not otherwise healthy younger people. I'm in that older group, so it's not.
Being ageist.
I'm there with you. But there's considerable questions that have been asked about, the attributing the deaths to COVID, et cetera. So that's just something to take into account.
So yeah, there's a lot of discussion, and whether you attribute a death to certain things depends on the rules. If if someone who's very extraordinarily debilitated, can't do anything for themselves, isn't conscious, has repeated respiratory infections, and they, and there's a fire where they live and they burn to death, would you say they died of old age because they couldn't get up and get out? Or would you say they died, the same with a car accident, where they died because of that cause? If they have a heart attack and you actually figured out that's what it was instead of them just being found dead, would you say that the cause of death was a heart attack and the others are confounding? So there are all these rules of how you attribute it.
Right, there's the famous, it's kind of funny in retrospect, but somebody saying that somebody died of a gunshot wound, but they also had COVID. So what did you attribute the death to?
So that's up to the physician is the
That's right.
exact thing that caused their death. And it could be this caused this, caused this. It's not a new question, and it goes long before COVID.
Right.
Another concept that's very important, goes back to our earlier question about children not dying, is years of life lost. So a 95-year-old bedridden that dies of whatever they die of, their years of life lost is not much. A 2-year-old, that's much greater. And so that's a measure of public health. Another thing that Governor DeWine in Ohio talks about is, he doesn't say public health, he talks about children not reaching age 60. And that can be a fifth of the children or a fourth of the male children not reaching age 60.
Well,
Is that due to obesity rates?
Well, it's a number of things. It's overdoses, it's obesity, it's heart attacks, it's car wrecks, it's all of the things. And
there's studies now being made about deaths from COVID among the vaccinated and the unvaccinated, and the preliminary results are not very encouraging in terms of what the vaccine does.
So COVID is back in amongst lots of respiratory viruses now. And, the question is, the next thing that comes along, how do we know? And what's happening is this bird flu. I heard last evening that a number, and they started looking for antibodies in a bunch of cattle veterinarians, and they're finding a lot of the antibodies to it, which is new. Because
So antibodies meaning they can fight it, or antibodies that
antibodies mean they've had it, their immune system has a memory of this specific
okay.
virus, so they must have been exposed because we don't have a vaccine. It's just one piece, but clinical diagnosis doesn't help. And the usual typing of the influenza, which is done in labs, doesn't pick up this variant. It has to have special typing. And so there's a call now that if you've got something that doesn't type adequately with this, send it on to get special labs. So we may see lots more of it. The question is it any more deadly than every other flu? Only one death that's known from that. But it's a question that we'll have to see, is the data real? Next slide.
Is like bird flu the same as like the bird flu that we had there, I don't know, probably 10 or so years ago, or is it different?
So this is a different one, and I'm if I were among public health doctors, I'd be ashamed to say I can't remember which one's which, H this, H that.
It was like H1N1, but I'm not sure if I'm
so there are all
remembering
these
that right or
different types, and this strain and that strain, and so just like COVID, it's always changing. And so flu and COVID are ones that are frequently mutating. Things like hepatitis A, the virus is very much what it was decades ago. So the vaccines, better. So this one right now, it's there. It's in a lot. So it has been identified in West Virginia in at least one backyard poultry thing, but it's identified in dead wild birds all the time. So it's here. Whether we're going to get it, don't know. And whether it's going to be seasonal or it's going to be all year long like COVID, don't know. So there's, we're ripe to all sorts of infection. And as technology improves and we can advance and say, oh, they got bronchitis, they got pneumonia. We don't know what type. Could have been bird flu, could have been swine flu, could have been all sorts of things. So we're putting names to them and looking for patterns. The response is the same for most, except a few things. There are actually antiviral medicines that can help, but right now they have to be started very early in the course.
Or if you lead a good, healthy lifestyle and get good nutrition, you can boost your immune system and have it at optimal health to fight off infection, because God gave us a good immune system to do that.
That's true. Taking care of yourself, being in best health, but even in 2018, the problem was lots of young people were dying from it, and that's why it's so memorable. Not just that people were dying, but young people, 18-year-olds, 19-year-olds. But yeah, definitely do all you can to improve your immune system and every other system. Next. Yeah, next. Okay, that's West Virginia.
Yeah.
Same pattern. But the numbers of deaths are smaller, so we're seeing each week fewer than 1 or 2 people, and and those become these people that were susceptible, and you'll hear about people that were pretty healthy 60-year-olds that get it and get critically ill and die. So it can happen. Same with the flu, and we're at those similar levels now of deaths. Next, so we go to the administrator report. It is. Ready? The administrator report.
Yeah, go right in. Since
So,
you're serving both roles right
We
now.
don't have one. No.
Yeah, so I'm getting all the permissions changed,
Yeah.
lots of computer permissions.
Are we looking for one?
Yes, I'll discuss. So first I wanted to just go over our organization chart, which probably should read every year. And there has been some confusion. This actually is very similar to what the 2021 chart looked like. I put executive officer next to health officer because sometimes there's questions, and in the code it says that the health officer serves as the executive officer. So that's so it's executive director, and and some health officers have that actually as the health officer and executive director, but just for misunderstanding of who's what. We have been recruiting. Early last week, the Division of Personnel forwarded 7 names from, I think, about 20 or so applicants. 7 names of people who met what they rated as meeting the job requirements, having sufficient experience. Interviewed 4 so far. Interviewing another 1 today. Diverse candidates with different backgrounds, and hopefully one of these people will be, and checking references, hopefully one of these people will be someone we can hire. To do that, we'll need board approval. So when we hire with the Division of Personnel, we have to make an offer to the person in writing and with a salary, and then the person has to formally accept it. Then we send it to the Division of Personnel, who then tells us what salary we can offer them after we've offered it, which makes it a little hard to say we agreed on this, and now you're telling me I can't. And we've had that with some people here. So it's a tentative, and then the other tentative thing which changed 2 years ago is the Board of Health has to approve the administrator's appointment. That could perhaps be done as a single special Zoom meeting that we immediately go into executive session and come out and vote. But it's
So putting us on notice that we may have to do a quick
Right,
Special
and
meeting?
you know, I mean, I'd rather not wait until the next regular meeting, but it could be something fairly simple. Have a few people meet the candidate or others, you know, in the resume. I don't think I've sent that, so we'll decide who it's gonna be, and then I'll forward the.
Do we have to approve before you make them the offer?
So I will have, at least one or two board members meet and see that they're acceptable, but no, this person will understand that this is tentative based on that, but I want selfishly, I want to get someone in the position who's, you know, capable as quick as possible. But also I want someone who I feel can manage the position without a lot of rework and putting out fires. So nobody that we've interviewed has been in this position, because if they've been in this position and want another one, they can go elsewhere for higher salaries, almost anywhere else. But I was pleased to see, you know, that we did have some decent candidates, and Lindsay and Alexis have been involved in the interviewing process. The next slide. You saw that our deficit was, I think, $200,000. This is our permit fees, the environmental permit fees for the last few years. So you can see we're poised to collect $150,000 or more in the next couple of months. So that's why I don't feel quite as awful about the budget looking at it. And that's just because it's the year they have to renew in July 1st. They have to renew before that.
Prior to
that. So unfortunately, this affects our financial statements throughout the year, as we're this far behind, because we're actually taking that. It's probably gonna be 300,000 now because we've increased our rates from last year, would be my guess. Is that we're splitting that into 12 equal things, which isn't really reflective. Just so maybe, you know, I talked with Amber about maybe having some similar graphs in the future, just showing some of these things. To when I just look at the numbers, I can't keep them all straight of where, you know, this is where we were last year. This is an important one. Next.
Yeah, that's helpful.
You know, and I'll do the same with the accounts aging.
Mhm.
You know, and I'd like to talk with you about other things you think would be helpful from your financial background, but looking at the different insurances, so most of those unpaid ones are in the 90+ days.
Mhm.
And then also I want to do the same with our different grants. There's a great deal of concern in the public health world, especially the local health department and others, about what's going to happen with federal grants. Are they going to be paused? That's not affected us that I know of, but as you know, we don't get money from the state or the feds every week anyway. It's like, okay, we put it in and maybe we'll get it this year. So it's owed, and we're up to date on most everything. I don't know what's going to happen. I don't think anything we're doing is going to be affected by diversity, you know, type changes. I do not think anything should be happening with family planning program or immunization program, except that, so that's always been voluntary. We do not do abortions. We do not refer people for abortions. If people ask us so, we can say that is one of people's choices, but we, you know, but we specifically in the family planning requirements, the laws, we can't be specifically referring. I could refer someone directly to an infectious disease doctor. I can't do that. So I don't think that should change. I'm sure things have changed, but vaccinations shouldn't affect us, except there may not be the surge in August of people who wanted vaccines because people have an option of opting out. So the final laws for West Virginia haven't been, they're moving forward with some things, but there are questions, but I do believe within 2 months, the legislature will have changed laws and the governor will have signed them, and we'll see what that is.
As of yesterday, from the news I was getting from the legislature is that they were going to, I don't know if they did or not, because I was too busy this morning to check, but they were supposed to pass legislation instating religious exemptions in West Virginia for the first time.
So and that will not involve the health, from what I understand. We'll have to wait and see what finally is the procedure, but it will not be me deciding whose religion is acceptable religion. That's not my role. We have never given a child a vaccine without parental or guardian consent. So, that's, we never do anything to a child without the consent.
Most of the kids coming here are people that want to get vaccinated versus being at the school, being told they have to be vaccinated. It's like,
Well, they come here to get them. So,
right.
so some of them aren't happy. Those people that don't want them, they have an out by whatever their out's going to be. And
That's determined by
they
the
don't
school,
have to
not by
come.
us.
We don't argue with people. If they come in and say, we don't want it, say, well, I won't give it to you.
Mhm.
I can't give it to you if you don't want it.
So you don't chase
That's
them down the
assault
hall
and
and
battery.
everything.
And as, and as a child gets older, if there's a 13-year-old who starts fighting and doesn't want it, we're not giving it. 4-year-old that does it, yeah, mom, hold them tighter. But as you get older, then, at what point does this become traumatizing at a different level to have people do that? So that it's not really going to change our interaction with individuals, except perhaps people that are really unhappy about it, they won't have to come here.
Right.
You could see from that, it's quite a variety of different vaccines we give for different reasons.
So we've got the budget, so the commission's budget, you guys are due in March, right?
Yeah, we have hearings scheduled for about 2 weeks in March.
2 weeks, okay. Are we putting?
So I
anything
have
forward?
not, so I need to get with you and Eddie Benitez to see that we're able to receive no information about that.
It's kind of awkward that we don't have an administrator at the moment that we have to put forth the budget.
So we'll work on that. So the other staff's going to be involved. The budget each year is pretty much based on last year's with some changes in staff. So Gino did put out the tentative personnel costs for this coming year with the PEI increases and stuff like that. So we grants, we know what we have presently. That could change up to the last minute. It certainly did in COVID right in through June with lots of stuff. But so yes, it is inconvenient, but
Doctor, when you're talking about budgets, have you all met David Bond yet? He's the chief finance officer, who works for David Bound, who works for, he's our chief finance officer.
I have not spoken.
Okay, he's very good. He's very approachable. And when you talk to Eddie Benitez, she will probably pull him in on the discussion.
So preceding my time here and I may not get this completely right, but since about 2010, the county commission has not provided extra money to the health department. They did before that. But since about 2010, the county gives us this space. The Board of Health is required in the code to provide the space for the health department activities. So we have the in-kind contribution, which a couple of years ago, they revalued that from about 70,000 a year to about 110,000 a year. But we don't get any cash. Some counties get cash. Jefferson used to, and that can help with the budget. This deficit that you saw on the thing, the out of compliance with reserve requirement, the reserve requirement is that we have in the bank the prior 3 months worth of expenses, which is in there. If we're below it, that's not to be allowed. We're always right at that edge. Especially with that last 200,000 not coming till the last couple months. Berkeley County, I don't know the number, it's 160 or 200,000. My understanding is that's what Jefferson used to provide for operations. Cabell County, Huntington, which is 92,000 people, they actually have a bond, just like we have a school bond, they have a health department bond, and their health department gets about $1 million a year from that, which they could offer a lot more services. Some of that is getting people who are just grants writer. They have a personnel director, finance director. That's the administrator here. So so anyway, there's a lot we could do with it. Most of our grants, those are very specific about what they can be used for, and there are things that don't neatly fit into a category. But so we're going to come and ask again. So when I started in the second half of 2019, I was told by the then county commissioner that not to come ask them for money until our budget was balanced, because we were losing 200,000 a year. So it's been balanced. That's probably the only good thing came out of COVID. It burned everyone out, but there was some infusion of monies for a little bit, and that's gone. So the big challenge for us now is to balance the budget without laying off staff, or there's always a right sizing, but it's not a jobs program, but there are a lot of services we can offer.
Well, I think like well and septic is a good example. If we're gonna have development here, we have to do all the requisite permitting.
Mhm.
And so we don't have the same, we have to adjust accordingly, so.
Looking at the census reports, one item on there is number of building permits, which is not exactly the same as number of septic permits, but it's a fair proxy. And in West Virginia as a whole, there's somewhere around 5,000. That doesn't, and in some counties it's 3. Jefferson, as I remember correctly, is around 1,300 a year. Berkeley's about 1,800 a year. So these two counties are probably more than half of the state's building permits.
Putting that into perspective, in the 20 years from 2003 to 2023, there were only 2 states that had a percentage drop in population. That was Illinois and West Virginia. And Illinois was just like 0.1%, but West Virginia's was more than 3%. So we're the state that's losing the population. Really is essence, we're the only state that's really losing population.
Actually, the last 2 years we've gained population. We started gaining population, and while the rest of the state's losing population, we're gaining population here. Yeah, which is always the struggle with Charleston, because everything has to be treated equally. Mm-hmm. Whether it's teacher pay, public health pay, all of that kind of stuff, and it's sort of.
Yeah, McDowell County has very different economic environment than we do.
Mm-hmm.
So it's
okay.
Things going forward.
So you'll be submitting something to the commission.
Yes.
And then hopefully this administrator position will be filled, and we'll kind of probably, he or she will have a crash course in budgeting, so.
Who was
we
the
have to know.
previous administrator?
Do you know Cisco?
Who's now the administrator for Shepherd's, the town of Shepherd's.
Shepherdstown, yeah.
City of
Municipality,
Shepherdstown.
yeah. And is he still on the JCBA? Is he still on?
I don't know.
I thought his role there was because of the health department, but I don't remember.
I don't know that, yeah. The opioid settlement money, I have not heard. Jefferson Community Ministries did reapply. The problem with their application, you asked, was that they did not have from the state tax office their certificate that they were a nonprofit.
Oh, good Lord.
Yeah.
Interesting.
That's the,
Real simple fix. You just look on the Secretary of State's website, you
So it's-
verify.
yeah, so it's,
Blast.
anyway,
They're
lots
not-
of little details.
They're not certified as a nonprofit.
Well, no, they are, but they didn't submit their certificate.
Yeah, it was supposed to be in the packet.
I
So the T wasn't crossed.
Yeah, so all you had to do was go on the Secretary of State's website and see that they're still valid and this is how they're formed, but
So, okay, that's.
brand new foundation, we already got a Doja, like, fine. All right, any other questions before we close the meeting? All right, do I have a motion to adjourn?
So moved.
Second.
Any discussion? All right, all those in favor, say aye. Aye. And reflecting an eye with a thumbs up. All right, we are adjourned. We'll see you next week, next month.
Well,